Listeners, welcome to a brand new season of Doc Talk Live. This is season 7, folks. As you all know, Doc Talk Live is a health show dedicated to educating our listeners about different health topics every week. And we do so by bringing on medical experts to answer your commonly asked questions. Be sure to send in your questions on our Facebook Live, and you can find more information on, of course, our Facebook page, Instagram page, Twitter, YouTube, and our website, doctalklive.com. That's DOCTALK live.com. And also, you may even hear these episodes on our podcast on Spotify, iTunes, and iHeartRadio. So, folks, my name is Dr. Parin Makadia, and I'm hosting today's show. Joining us in the studio is Dr. Florian Dibra and Dr. Vikas Patel to educate and discuss on a variety of topics, including knee replacements, hip replacements, and rotator cuff tears. So if you have been recommended any of these orthopedics procedure, you may have questions about their benefits and risks. So today's show will tell you more about what to consider before getting these procedures or surgeries. So Dr. Patel and Dr. Dibra, welcome to Doc Talk Live, and thank you so much for being part of this show. Please tell our listeners a little bit about yourself.
So thank you, Dr. Makadia. Thank you, Doc Talk Live, for hosting myself and Dr. Patel. We're very excited to be here today. So I'm an orthopedic surgeon, fellowship trained in hip and knee replacements, and I practice mainly in the Frisco, Texas area. But we sort of have a reach in quite a bit in that North Dallas region. I am married with 2 kids. We moved here from Florida, so we're very, very excited to be here and be able to help our patients in our community.
Thank you for having me on here. I'm Dr. Vikas Patel. I'm a shoulder and elbow fellowship-trained orthopedic surgeon. So I'm happy to be back here in Texas. I was born down in Houston, and my wife and I are, with our one daughter, are happy to be back here in the Texas area. And, love to be able to take care of patients in the North Dallas area and be able to take care of everything.
Excellent. Thank you so much, Dr. Patel and Dr. Dibra. So we have a very loaded show today, so we're going to be going back and forth between knee, hips, and shoulders. But let's start with you, Dr. Dibra. So what is the muscle-sparing knee replacement, and what is the muscle-sparing hip replacement, if you could tell our listeners about it?
Sure. So as our understanding of hip and knee replacements evolves, so do our techniques. The majority of hip and knee replacements being performed today in this country involves removing or temporarily cutting some of the muscles while we do the approach and then repairing them at the end. Muscle-sparing hip and knee replacements avoids that because studies have shown that the less soft tissue damage you can perform during your surgery, the quicker the recovery, the better the range of motion, the less pain, the stronger muscle our patients have. And this is the reason why I offer this to my patients, which is a unique approach in order to get them up and moving right away.
Excellent. Dr. Patel, can you tell our listeners what is a rotator cuff?
Sure. So the rotator cuff is comprised of 4 muscles that arise from the shoulder blade and attach onto your shoulder to help you provide range of motion to your shoulder. There's different things that can injure your shoulder, in particular your rotator cuff, from either wear to daily wear and daily activities versus falling on your shoulder and having a trauma. And so, patients typically hear about getting a rotator cuff tear, which can be either a partial thickness rotator cuff tear, which can be rubbing your pants for a long time and it gets thin, versus a full thickness rotator cuff tear, which is, say, if you took a knife and cut a hole in your pants.
Gotcha. That's pretty interesting. Dr. Dibra, so going back to the hip and knee replacement, how long are these surgeries?
So the surgeries are fairly quick these days. If you're going to cut less, you're going to have to repair less, and so that shortens quite a bit the surgery time, along with other things that we do as far as using better implants that do not need to be with cemented, which is what's called press fit. It's more of a natural ingrowth of the cement or of the implants. So all in all, this actually shortens the procedure, and it's about 45 minutes for both a hip and knee replacement these days.
45 minutes.
45
wow.
minutes. That's it.
And that can be done obviously in an outpatient setting, or someone has to be hospitalized.
That is the new trend now in the United States. More and more patients are going to the outpatient setting, and as well as the same-day surgery. So some outpatients, just because you do it in a surgery center doesn't mean that you get to go home. But in my case, my patients, If it's in a hospital setting or in a surgical center, they go home same day. That's what's great about the surgery these days.
That's great to know. Just to piggyback on that, how safe are these surgeries?
So the surgeries are very safe. I, whenever possible, avoid general anesthesia. So my patients get what's called a regional block or a spinal block, as well as some specialized blocks around either the knee or the hip. This allows them to basically just get some light sedation. They take a nap. They're very comfortable. They don't hear. They don't feel anything. But it's much safer because they don't need a breathing tube. They don't need a lot of time to recover afterwards as far as nausea or any drowsiness. So that's why they're able to go home same day and feel great.
Gotcha. Now moving up to the shoulders. So you were talking about the rotator cuff and rotator cuff tear. What are some of the symptoms that the patients or folks out there should be looking out for?
Sure. So most of the time, patients will have pain in their shoulder, and particularly radiating kind of to the outside of the shoulder where your deltoid is. You'll also have a lot of pain with overhead activities. So say if you're trying to change a light bulb or something, you may have difficulty doing that activity. You also can develop pain and weakness with getting even something like a glass of water or a bowl from the cupboard, bring it down to the countertop can be very difficult to do, and you'll have weakness doing that.
But now, what happens if they don't seek any medical attention and this is left untreated?
That's a great question. So I'm going to give you a couple statistics here. So there's a great study that they took a group of patients who had absolutely no pain in their shoulder and didn't have any symptoms, and they got an MRI on all these patients. And so what did they find? 54% of patients had an abnormal MRI with either a partial thickness or full thickness rotator cuff tear. So this kind of shows me that lots of people are walking around doing their normal day-to-day things and have a rotator cuff tear. So what do we know about what happens to those rotator cuff tears over time? Well, we know that they rarely heal on their own, and if they're going to get bigger, and if they do get bigger, you're going to start to have increasing pain and weakness. And so, that's just the natural history of a rotator cuff tear. And the great thing is that since lots of people are living their life with a tear, easy things like physical therapy are something that can be done early on in the process to hopefully get you back to doing the things that you want to do.
Gotcha. For the folks who are just joining us, you are listening to Doc Talk Live, and we are live in studio with Dr. Dibra as well as Dr. Vikas Patel, and we are discussing hips, knees, and shoulder surgeries. So going back to the hip and knee, Dr. Dibra, how big are these incisions for the surgeries that you were just mentioning a little while ago?
So what's nice about the surgeries, they're not just muscle sparing, they're also what we call minimally invasive. So it all starts from the beginning. So the incision is one of the biggest factors for my patients. The traditional approaches, especially for the knee, the incision, you can see them all the way down from the mid-thigh to sometimes mid-shin. These days they're being done anywhere about from 4 to 6 inches, and what I do a little bit different than most surgeons out there is I actually curve them a little bit. So I don't make a midline, I actually make a curved incision around their kneecap, so they are able to kneel right afterwards. They're able, when they do physical therapy, they're not putting any undue stress. As far as the hip goes, the majority of my hip replacements are done with what we call anterior hip, or that's the quote-unquote muscle-sparing approach. It's about 3.5 inches for females, about 4 inches for males. And again, this allows for earlier recovery, small incision to heal. Patients don't have to do anything about as far as postoperative care. These are all underneath sutures. This is all surgically glued. They can shower right away because the bandage that we put on is waterproof. So it's very, very minimal as far as postoperative care and burden to our patients.
It's almost like they didn't even have surgery, huh? With the look of the incisions.
We are able to share a lot of our postoperative patient videos, and one of the most common that we get is where is the incision for the patient, because of what they're used to. And patients come back to us and tell us in a grocery store and they see their incision and then the other patient's incision and say, how is this possible? And this is half the size, because that's what most surgeons are doing these days. They're sort of understanding that the less you cut, the easier the recovery.
Gotcha. So if you could shed some light on what's a typical recovery time for the knee and hip replacements? So
patients are up and going the same day of surgery. They work with physical therapy twice before they get discharged. They are made sure that they are safe to go home. They go over steps. They are taught how to use a walker or a cane. At 2 weeks, I see all my patients after a hip or knee replacements, and I have a lot of videos documenting them essentially walking without a walker or a cane. So at 2 weeks, I tell them you're able to walk without any assistive device, And then at 6 weeks, most of my patients are back at work. Some are as soon as 1 week, especially the hip replacement patients. I have a patient this Friday, believe it or not, that she's having surgery on Friday and would like to go home, would like to go to work on Monday, and she's very, very determined to do so. So that's what's nice about these surgeries, that we're getting patients back at home right away. We're getting patients back at work and back to doing what they want to do right away.
Excellent, excellent. Dr. Patel, you were mentioning about the symptoms of rotator cuff and what happens if you leave it untreated. But when should, and you said people walk around with these tears, right? Mm-hmm. When should they see a physician like yourself?
Right. So, I think anytime that you have shoulder pain, that's not normal. And so I think you should be evaluated, in particular by, an orthopedic surgeon and someone who's trained in the shoulder. Whenever we see patients with shoulder pain, there's lots of different reasons that you can have shoulder pain, whether it be from your rotator cuff tear, but it can be other things like frozen shoulder. You could have referred pain coming down from your neck. You could have arthritis. And so making sure that you see someone that is specialized in this area, they can really be able to tease out the differences and find out what's really going on with your shoulder. Because you don't want to get an injection or undergo physical therapy or surgery and not get any better from it. My goal for every single patient is I want you to get better. I don't want you to be different.
That was one of the questions I was going to ask as to why is it necessary to see a shoulder trained specialist? What will you do different than, let's say, a general orthopedics would be doing? Right. So, in my training, I spent my fellowship year seeing kind of the worst of the worst and being able to see the whole gamut of pathology that's dedicated directly to the shoulder. So, we're able to learn and see surgeries that not every person can do. Certain surgeries like shoulder replacements and tendon transfers for rotator cuff tears are things that shoulder specialists can do that not your average general orthopedic can do. And so that's why, shoulder specialists will be able to give you the best option and not just an option. So, for the folks who are just joining us, you are listening to Doc Talk Live, and we are discussing hips, knees, and shoulder surgeries with Dr. Patel and Dr. Dibra. Dr. Patel, so what kind of surgical options are there for patients with rotator cuff tears?
Right, so it all depends kind of on the size of your rotator cuff tear. So you can have anywhere from a small rotator cuff tear to a massive rotator cuff tear. If you have a small rotator cuff tear, the nice thing that the technology has advanced so that we can do outpatient arthroscopic surgery, which means we can make small incisions around the shoulder and then look at your rotator cuff with instruments about the size of a pen. During that, we can go in, clean up the torn tendon, and attach it back down to bone. If you have bigger tears, the arthroscopic option may not be as best for you. We may have to do certain things like a tendon transfer where I take a tendon and reconstruct your rotator cuff so that way you can be able to move your shoulder and be able to do activities further away from your body. And if you have arthritis along with the rotator cuff tear, what I can do is do a shoulder replacement. And so I know it sounds kind of crazy that, I have a rotator cuff tear, but I have to have a shoulder replacement. But what it allows is that your deltoid muscle can then take over functioning for your torn rotator cuff. And by replacing your ball and socket with metal and plastic, you can actually have a pretty good functioning shoulder with very minimal pain.
That's very interesting. So folks, we do have two specialists on our show and take advantage of this. Dr. Dibra, you were mentioning about a quick recovery time for most of your patients, but what are the precautionary measures that you ask these patients to take after the surgery is done?
So for knee replacements, there's really no precautions. All I really encourage them to do is get physical therapy for strengthening and range of motion. For the hips, you hear out there what's called precautions, so anterior versus posterior precautions. So if you have a posterior hip replacement, there's something called posterior hip precautions, which means no bending over 90, no turning your leg in sort of that sitting in a toilet positions. And then as far as the anterior hip precautions, no extending your hip backwards or rotating the leg out. However, because we're understanding these replacements much better, we know exactly what the repairs need to take place. Even the posterior hip precautions, they're becoming an outdated thing. There's studies not coming out that shows that You don't have to, if you have a well-positioned implant and a very well healed or a repaired capsule and muscles, you don't have to do the precautions anymore. So for my posterior hip patients or my anterior hip patients, which is the muscle-sparing patients, I caution them just to as an added precaution, but I tell them if you need to go out there and live your life, you can go out there and live your life, because I make sure in the operating room that I'm placing these implants where they need to be placed, and I make sure that I do a really, really good repair that they can go ahead and, because some studies were showing that people that were observing these precautions were less happy, they're sleeping less because they're constantly having to worry about which position is the leg in, and their satisfaction rates were actually much lower, and it didn't really show much more benefit. Those patients were not dislocating more than the other patients that weren't observing the precautions. So slowly, most surgeons are abandoning those precautions.
That's quite interesting. So when do you recommend they start physical therapy after these surgeries?
Physical therapy is right away. So there's no weight-bearing restrictions. They can get up and go. So day zero, what I do very nicely with my practice, I set everything up ahead of time. And not only the physical therapy, I set up the home health if they need to have a nurse visiting to them in their home, or we set up outpatient physical therapy. Either way, the key is to set this all up prior to surgery, because last thing the patient needs to worry about is, when is my surgery, when is my physical therapy going to start, am I missing a session or two? That's all taken care of. It starts right away. It's about 2-week session for both hips and knees, and then the knees sort of continue on with some outpatient surgery afterwards, versus the hips, patients recover so well and it's just up and go and go back to your regular activities.
Gotcha. So you do recommend like a formal physical therapy rather than saying, hey, these are the exercises at home that you do?
I do. I have some, my younger patients, my really motivated patients, my really fit patients, which again, in the world of arthroplasty, in the world of hip and knee replacements, that's typically not our patients. My patients are usually a little bit in their late 60s, 70s, or 80s, so they tend to be a little more deconditioned, especially if they live with arthritis longer than some folks that get to it right away. So those folks certainly need our physical therapy, and then some ones that, especially in the time of COVID, I understand it's very difficult to either have somebody come to your house or be able to go somewhere. Patients ask me for exercises, and I give them printouts, and as long as they do those exercises at home, they're just as safe and they cover just as well.
That's good to know. And these patients can return to work on an average basis in how many days or weeks?
So my hip replacement patients, I've seen somebody go to work as early as 1 week. I sort of tell them that from a driving precaution standpoint, studies are a little split. Some studies say that reaction to braking can return either at 2 weeks or 4 weeks. I think the biggest key is to be off an assistive devices, so you're not using a walker or cane, to be off narcotics. That's the most important thing. And then as long as they have a couple weeks of physical therapy and they're sort of back to seeing me in the office, and they're not walking with a walker or a cane, I sort of slowly tell them, you can go ahead. And it all depends, right? Not everybody is doing.
But on average, it's 2 weeks.
It's 2 weeks or so, especially the folks that are able to get back to work and it's more of a stationary sort of setting, versus folks that have to do a lot of steps or truck drivers or those sort of things. They are leaning more towards the 4-week mark, but it's still remarkable compared to what it used to be, which would be like 3 months. That would be sort of the standard with all patients.
Okay. Now, switching gears to the shoulder surgery, Dr. Patel, how long, the surgeries that you mentioned, how long does it take for recovery for the surgery, the rotator cuff surgery?
Right. So it all depends on which surgery that we do. So if it's arthroscopic rotator cuff repair, you're in a sling for about 4 weeks or so, and then you get started in formal physical therapy. With the rotator cuff repair, physical therapy is very key, because you want to make sure that the therapist can be able to help you get your range of motion and your strength back, and that's very difficult for patients to be able to do that on their own. And you don't want to undergo a surgery and where you have pain and stiffness in your shoulder, and you end up with pain and stiffness afterwards. So that's why therapy is really needed for that. If you have the bad arthritis and rotator cuff tear and you need a shoulder replacement, in my practice, what I do is my patients don't actually need physical therapy. They're in a sling for about 4 to 6 weeks, and then after that, I show them exercises that they can do on their own, starting at the 2-week mark. So then that way they can be able to avoid having a physical therapist work with them, and that way they can be able to live their life on their own, and especially right now with COVID, be able to avoid that and having to interact with another person that you just wanting to be safe as much as possible.
Got it. So what are the precautionary measures you tell your patients to take after the rotator cuff surgery?
Right. So I think the main thing is that if you're feeling pain when you're doing a certain motion, that's not normal. So pushing through pain is only going to hurt you in the long run. So I think making sure that you don't push through pain. Know the limits of your body. That's going to be the main thing, because if you start moving too fast or start to do too many exercises a little bit faster than you should, you can end up re-tearing or not healing your rotator cuff, and then you're in the same position that you were before. So making sure that you don't go too fast with some of your motions, and not lifting anything too heavy for about the first 3 months is a big key. So it makes it very tough for patients that are, in particular, manual laborers. It can end up being a little bit longer recovery time, because it's tough to go back to if you need to put up drywall or use a hammer. It can be tough in the long run, but it allows you after the full recovery to be able to get back to doing your job.
My other question that I have is, can this tear happen years from now? A re-tear, can that happen?
Right.
After the surgery, obviously.
Right, so that's a great question. So just because you have the surgery to fix your rotator cuff doesn't mean that, one, it'll heal. We now know that studies show that a lot of times your rotator cuff doesn't actually heal after the surgery, but you do get a lot of benefits from decreasing your pain and getting your strength back. So no matter what, in any time point after surgery, you can end up re-tearing your rotator cuff, and so you may have those symptoms that you had previously with pain and weakness. So that's why once I operate on you, you're my patient for life, and so I make sure to kind of recheck things just to make sure that if things do go awry, or if there are symptoms that you're experiencing that are new, I make sure that you're able to stay on top of it and not miss it, and you lead to worsening shoulder pain and kind of more dysfunction than you really should.
Excellent. Dr. Dibra, a similar question for you. If someone did a hip replacement, knee replacement on the same knee, what are the chances of having them to do it again years from there?
So a lot of patients, that's a great question, because a lot of patients say, how long does this last me?
Correct.
How long does a hip replacement last? How long does a knee replacement last? Because these are metal and plastic materials, and over time the plastic can wear out. However, with the newest technology, they're making sure that these things are very, very tough, and they're wearing at a 0.0001 millimeter per year rate. So, I know studies out there. Where we get these information from is something called the registry data. We don't have a very good one here. Other countries have a better one, such as UK and Australia. And there's studies that show up to 25 or 30% or 30-year follow-up. Almost 95% our knees and hips are still in the patients and not needing any revision for whatever reason. So I tell them at least 30 years, which is what we have now with registry data. They're doing very, very well, which means with the newer technology, they're going to perform even better. But it is nice to have these done. It's somebody who has low impact activities, not somebody who is a 40-year-old runner that wants to continue to run because they may not be able to do those activities anymore. That's why the majority of hip and knee replacements are being done in folks that have retired. They're sort of slowing down a little bit in their sort of low impact activities. But even my 50-year-olds, my 60-year-olds, we're making sure we're putting in the implants in the right place, and they're going to last a lifetime.
Gotcha. And early on the show, you mentioned anesthesia blocks, and this question goes to either one of you. Can you tell a listener what exactly that is? Because people know about anesthesia, but they don't know. And again, this is an anesthesiologist question, but I figured that, since you mentioned it.
Yeah, but maybe for another time. So before I actually did orthopedics, I was an anesthesia resident. So I did that for a couple of years training, and then I switched careers. So I do have a little bit of background in that. So, but anyways, to avoid general anesthesia, you need to have some sort of a block. Okay, that's sort of what you people hear. And regional anesthesia or blocks are synonymous terms. So for my hips and knee replacements, my anesthesiologist performs something called a spinal. Okay, so it's a needle which could be familiar, mostly females. I ask that questions, did you have either an epidural or spinal for your vaginal delivery or C-section? They say, oh yeah, sure, I know what that is. So essentially it numbs the lower half of their body so they can't feel it. In addition to that, because the spinal is only going to last that day, I do some extra blocks, or my anesthesiology does. And basically they're able to have almost 72 hours worth of coverage. And this way they don't have breathing tube. They can basically just take a nap and be sedated. And I think similar, and I'll leave it to Dr. Patel, in the shoulder.
Yeah, exactly. So in the shoulder, we are also able to do blocks, which is great. It can help numb the shoulder and kind of give you great pain relief for a good 3 to 4 days. However, we can't do it as nicely as in the hip and knees, because if you did the same type of spinal, it would knock out your diaphragm and you wouldn't be able to breathe. So you still have to have general anesthesia, but the blocks have allowed patients to take less narcotics and recover much faster.
Excellent. Thank you so much. We are approaching the end of our episode today of Doc Talk Live. Folks, remember to check us out on our website, Facebook, Twitter, Instagram, as well as you could listen to this on podcasts on Spotify, iTunes, iHeartRadio. Dr. Dibra and Dr. Patel, thank you so much for coming on our show, and hope we could have you back again sometimes in the near future. This is Dr. Makadia signing off. Stay healthy, America.